Hello, this is again Nick the PA from Brooklyn, New York. This is my presentation for Radiology PANP Board Review Notes. And if you have any question or suggestions, please email me at my email, which is very simple, NICK, M like Mary, D like dog, the number 1, at gmail.com. Let's start with slide number 2. Let's discuss plain X-rays. First is a chest X-ray. The chest X-ray is the best initial radiological test for all forms of pulmonary complaints such as cough, shortness of breath, or dyspnea, chest pain, particularly when it's pleuritic or changing with respirations, sputum, and hemoptysis. The chest X-ray is also the best initial radiological test for all forms of abnormality on a physical exam of the lungs, including 1. Rales and rhonchi, 2. Wheezing, 3. Dullness to percussion, 4. Chest wall tenderness, 5 is tracheal deviation. Let's go to slide number 3. Also, if we have a possibly superior cover syndrome, which is a jugular venous dilation, plethora of the face, venous distension of the chest wall. Could be 3 types. Posterior, number 1, posterior anterior PA film. This is a standard of care when the chest X-rays is done. To get films, the patient's supposed to be standing up. Widening of them, there is a clinical tip here which states that widening of the mediastinum on a PA film is the best initial test of dissection of the thoracic aorta. Also, we have so-called anterior-posterior films, and this type of films are the answers for unstable patients which are too sick to stand up for a PA film. They're often done with portable chest X-ray equipment. Chest X-ray is the initial done in the intensive care unit, and they are with AP films. Also, we have so-called decubital films. These X-rays are done to evaluate for pleural effusion, and they're found on a PA film. The patient lays down on each side, and the effusion is confirmed if the fluid in the chest is freely mobile and forms a layer on the side of the X-ray. There is a clinical tip here which states that decubital X-rays are the answer when the diagnosis of infiltrate from pneumonia cannot be distinguished from effusion. Also, we have so-called apical lordotic films. This type of films are almost never the right answer. Lordotic X-ray of the chest is done when the patient is leaning backwards to take the ribs out of the way in order to examine the upper lobes. Lordotic films were originally the best initial test for TB, which has an increased predilection for the apices of the lungs. However, whenever apical or aortic films may be done, CT scan of the chest is generally the best initial test. There is a so-called lateral chest X-ray. The lateral chest X-ray is done to help identify the precise location of the infiltrate, which is found on a PA film. Lateral X-rays are the best initial test for effusion since they detect as little as 50 to 75 milliliter of effusion. Let's go to the next slide, slide number 4. The PA chest X-ray become abnormal with effusion only when it is 200 or 300 of the fluid which have been accumulated. There is so-called abdominal X-ray. There is only few indications for that. The best indication for an abdominal film is ileus or small bowel obstruction. Ileus or small bowel obstruction. Abdominal X-ray of the ileus will show multiple air fluid levels in the small bowel. However, abdominal X-ray is not accurate for the stone of the kidneys and will miss at least in 20% of the cases. Abdominal X-ray is not reliable to find air under the diaphragm because of it does not always visualize the top of the diaphragm, especially in a tall person. There is a clinical tip here which states that for perforation of the bowel, get so-called upright chest X-ray, not an abdominal X-ray. Abdominal X-ray is good only for ileus. There is so-called bone X-ray. The X-ray of the bone is the best initial test for osteomyelitis. You will see elevation of the periosteum. The long-standing bone infection give destroyed bone in the periosteal new bone formation. Also, it will take at least 2 weeks for the bone X-ray to become abnormal with osteomyelitis. You should still do this study first. You only obtain an MRI of the bone or a nuclear bone scan if the X-ray does not show osteomyelitis. Wow. And there is so-called skull X-ray. This is no first-class indication. There is no first-class indication for skull X-ray. Skull X-ray is not the best initial or most accurate test for anything. A normal skull X-ray does not exclude intracranial hemorrhage, and an abnormal X-ray does not mean, let's go to the next slide, slide number 5, does not mean hemorrhage. There is a clinical tip here which states that skull X-rays are rarely correct for any question. Next is computer tomography or CT scan. There is a head CT. Here, the non-contrast head CT is the best initial test for in several occasions. First, severe head trauma, especially if you have loss of consciousness or altered mental status. 2, stroke, and 3, any form of interstitial bleed. including subarachnoid hemorrhage. If we do a CT scan with contrast, we need to know that cancer and infection will enhance the contrast. You cannot distinguish between neoplastic disease and abscess by the CT or MRI. But the best head CT with contrast is the best initial test for any form of intracranial mass lesion. Remember two things. There's not other contrast with several so let's start from the beginning. Cancer or infection will enhance with contrast, but you cannot distinguish between neoplastic disease and abscess by CT or MRI. But the head CT with contrast is the best initial test for any form of intracranial mass lesion. And there is two clinical tips here, which states that do not order contrast with severe renal disease. Hydrate with saline and possibly use bicarb or N-salicylcysteine with mild renal insufficiency. And number two, stop malfunctioning stop metformin prior to using the contrast. Next is abdominal CT. This study should be performed for both intravenous or oral contrast. Oral contrast is indispensable in outlining abnormal structure, but they are personal. Let's go to the next slide. Personally, we are not against each other and would otherwise be difficult to visualize. Abdominal CT is also good for a couple clinical situations like retroperitoneal strictures. Organs such as pancreas are difficult to visualize with sonography. In sonography, the transducer is placed against the anterior abdominal wall. This makes it difficult to visualize structure which further are from anterior abdominal wall. Number two, appendicitis or other intra-abdominal infection. Number three, most accurate test is so appendicitis and other intracranial infections, and it's the most accurate test for nephrolithiasis. This is a case in which contrast is not needed. And also masses within abdominal organs such as liver and spleen. CT is the most accurate test for diverticulitis. There is a clinical tip here which states that choose the abdominal CT to visualize the pancreas. Tip, there is a clinical tip which states that the CT is the most accurate test for kidney stones. Let's go and move to the next, which is a chest CT. When there is a chest CT, is the answer of the test. When? So, number one, when we have a hilar nodule such as sarcoidosis. Number two, mass lesions such as cancer. Three is cavities. 4 is interstitial lung disease. CT adds additional considerable definition for the chest compared to the chest X-ray. The chest X-ray shows only interstitial infiltrates. The CT shows much as details as evaluation of the parenchymal, for evaluation of parenchymal lung disease and interstitial infiltrate. Pulmonary emboli, this is evaluated by spiral CT or CT angiogram, which is supplemental to the VQ scan to confirm pulmonary embolism. Let's go to the next slide, which is slide number 7. There is a clinical tip here which states that CT is neither the best initial or the most accurate test of the bone. Next, which we need to discuss, this is the MRI. The MRI is the most accurate test in all central nervous system disease, with exception when we are looking for a hemorrhage. The indication for use of contrast with MRI is the same as CT scans. If we see a contrast defect, cancer or infectious mass lesion. When the MRI is the answer of the test, when we have number 1, demyelinization disease such as multiple sclerosis. Number 2, posterior fossa lesions in the cerebellum. Number 3, brainstem. Number 4, pulmonary lesion. Number 5, vascular defects. And structures. Pituitary lesions, bone lesions, particularly osteomyelitis. MRI is the best to visualize bone, although cannot determine the precise microbiological etiology, and spinal cord or cerebral lesions. There is a clinical tip here so there is a clinical tip here. With cancer and infection, the radiological test is never the most accurate test. The biopsy is. And let's talk about ultrasound or sonography. When the ultrasound is the answer, when we have number 1, gallbladder disease, such as the ductus for straining and obstruction, renal disease, although CT is more sensitive for nephrolithiasis. And number 3, gynecological organs such as uterus, ovaries, adnexa. And number 5, prostate evaluation in so-called transrectal approach. Let's go to the next topic, which is endoscopic ultrasound. EUS, or endoscopic ultrasound, is the most accurate method for assessing number 1, pancreatic lesions, particularly of the head. Number 2, pancreatic and biliary distal disease. Number 3, is gastrinoma vocations such as Zellingen-Ellison syndrome. With EUS, sonographic device is placed at the end of the scope and placed into the duodenum to allow outstanding visualization of hard-to-reach intra-abdominal structures. Let's go to the next topic, which is nuclear scans. Number one is HIDA, or hepatobiliary scan. And it's clear only if the functional test of the biliary system will allow detection of the cholecystitis. Number two is a bone scan, although equal to sensitivity to MRI for detecting osteomyelitis. Bone scan is not near as specific as the MRI. Then we have gallium scan, which is used for fever of unknown origin. Gallium follows the iron metabolism and is transported on the transferrin. Calcium increase in uptake with infection, and in some cancers become a increased iron deposition. So-called indium scan, another test for fever of unknown origin, superior in assessing the abdomen, which can be obscure in the gallium scanning. Indium is the target, targeting the white blood cell scan. The patient white cells are targeted with indium and then re-injected to see where they localize to detect the infection. VQ scan, or ventricular perfusion scan, a normal VQ scan, especially excluded a pulmonary embolism. Low productivity scan will have a clot in the 15% of the cases, and high probability scan do not have clot in 50% of the cases. VQ scans are no longer the standard of care to detect pulmonary emboli. It is been the replacement of the spiral CT, and it is being replaced by spiral CT or CT angiogram in order to confirm. Let's go to the last slide, number 9, to confirm the PE. So-called MUGA, or MUGA, or multiple gated acquisition scan, or nuclear ventriculography, is the most accurate method to measure injection fraction. And this is, which is to finish the lecture. Thank you so much for your attention, and see you to the next lecture. Thank you.